Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME meetings. Today we are honored to have our great speaker, Professor Mohamed Hani Hafez, the past president of Egyptian Society of Nephrology, the current president of Afran, and the current MISOT General Secretary. Professor Mohamed Hani Hafez is the head of Scientific Committee of Arabic Board of Nephrology, and he is well known by his updated informations in nephrology, his continuous share in continuous medical education in everywhere in the world, ISN, EDTA, Afran, in addition to being the president of Afran, and MISOT, every scientific committee, he is present, Dr. Mohamed Hani Hafez, and is present, always updated. We cannot find anyone better than Dr. Hani to give us this lecture about what is new in all nephrology conferences. If you remember, and we will find the recording of this session, we had this session about 1 year later, giving the recent informations about the recent conferences in the past year, and now in this past year, 2022, what happened till now, mid 2023 in nephrology conferences. We are waiting Professor Hani to give us this resume and this summary of informations. Unfortunately, we are waiting of our second great moderator, Professor Maya Hasaballah, which was expected to be with us, and we are expecting to be with us within minutes from now to share us this very important session. Till now, not to consume your time and to enjoy every minute, we are to start. So please, Dr. Hani, start your lecture about recent nephrology conferences. Before you start, I would like to thank.
Thank you very much.
I would like to thank our moderator today, Dr. Rami Abu Bakr, for his work regarding the session and the coming work in our group. Please, Professor Hani, start.
Thank you very, very much, Professor Yasser, for this very kind introduction that I don't deserve. And it's my great honor and privilege to be with you tonight, trying to shed some lights on the last congresses, and I will divide my talk into two parts. The first part will be concentrating on the EDITA of Milan that was a few days ago in June, and the MISOT, which was last month. And the second part of the talk will be the high impact trial that took place during 2022 and the early 2023. So let's start with the first part, what happened in the EDITA Milan. Actually, I will start by the basic science advances, and this was the plenary session given by Dr. Alberto Mantovani, speaking about non-resolving inflammation and how a defensive mechanism transforms into a major threat to human health status, whether being responsible about the oncogenicity or about the renal diseases. So he actually tackled two important aspects in this talk. The first was the interleukin-1 system and its role. And as you know, the interleukin-1 is very important in the initiation of inflammation and even in malignancy. And therefore, we have here in this graph the effect of the interleukin-1 B inhibition with canakinumab on incident lung cancer in some patients. And the interleukin-1 is required for tumor invasiveness and angiogenesis, and therefore a blockade of the interleukin-1 would be very beneficial to halt some of the tumors, even if they are metastatic. And the second basic concept that he introduced in his talk was speaking about the PTX3. This is actually the long pentraxine, and this long pentraxine maybe is a new name for the nephrologist, but it has an important role in different kidney disease. PTX3 level are increased in patients with kidney disease, and the level correlate with proteinuria and are associated with endothelial dysfunction. And in patients with CKD can predict the presence of cardiovascular disease and even predict the mortality in dialysis patients. So this basic advancement in recognition of long pentraxine role is important for us to be acquainted about its role in the prognosis of our CKD patients. Another advancement in the basic science will go more in the direction of pathology by the super resolution microscopy, the next generation advance in nephrology. And actually, this talk was presented by Dr. Nicole Endlich as a sort of recuperation of what is new in the basic in Milan. And this super resolution microscopy has been invented by these three men that you see in the picture, and they got the Nobel Prize in 2014. And actually, it is a new light microscopy technique. It's a light microscopy. It is not immunoperoxidase. It is not electron microscopy. So it is a simple light microscopy with new physical abilities. And the value of this super resolution microscopy is that it can detect the podocyte, and it can detect the podocin and the synaptopodin, as you can see in this picture. And it can give you a panoramic view of what's happening in the biopsy, which is different from the electron microscopy, because as you know, the electron microscopy concentrates on 1 to 3 glomeruli only. So how can 1 to 3 glomeruli from the 1 million human glomeruli represent the real pathology? So it is important to depend on this light microscopy-based technique to advance our knowledge. And in the past, it was only possible to study podocyte food process morphology by electron microscopy, since their size is below the optical resolution of a light microscope. But due to these inventors, now we can see by light microscopy the new advances, and I will give you some example and some picture. The super resolution microscopy. Actually, it has got 5 applications. One of them is called SIM, and we'll go to it in detail, which is structured illumination microscopy. The second is called the STED, stimulation emission depletion microscopy. The third is called STORM, and the fourth is called PALM, photoactivated localization microscopy. And the last is called PEMP, or podocyte exact morphology measurement procedure. This super resolution microscopy will make a new revolution in nephrology, because they will enable us to detect different biomarkers like Claudin-5, for example, in the biopsy. It will give us a chance to quantitate the messenger RNA. We can see the glomerular basement membrane, the endothelium, the mesenchymal cells, and the podocytes رأي العين كما يقولون. And these are examples of what can we see. This is the glomerular filtration barrier. Here you can see the podocyte in purple, the glomerular basement membrane in red, and the endothelial cell in green. Even the slit membranes can be seen, and mesenchymal cells can be seen in green. And the Claudin-5 that I give you an idea about is a biomarker for predicting early food process effacement, could be detected here in these biopsies. You can see the Claudin-5 here. You can even expect how a drug could be effective on the kidney or not. And this is an example of the nephroprotective effect of the drug known as semaglutide in an experiment. And immunostaining is, as you know, is time consuming, and it may take a week to get an electron microscopy. Although the same technique that I will explain to you soon takes only 1 day, and it is very rapid. You can just use 2 or 4 co-staining by podocin, for example, and in green, and synaptopodin here in violet, to get an idea about what's happening inside the glomeruli in detail. What is SIM? SIM is structured illumination microscopy. Actually, it has been discovered by the German in 1963, but its application in medicine took many years until nowadays it is it is present as a technique. And you see here some of the publication of this SIM, or super resolution stimulated emission depletion in optically cleared kidney tissue, and in some of the diseases visualization of the SIM, a new approach to nephrotic cases. So I think in the future we will ask our dear pathologists to have these techniques, because it is the future. This is the advances in the basic science. I started by some immunological aspects and then some pathological aspects. Now let's have a new concept of the clinical trial. Nowadays, the world is speaking about what we call not the randomized control trial that are highly focused and fine-tuned sources of data, but about what we call real-world evidence, which takes what is happening really in the world, address the question of safety, effectiveness, cost effectiveness outside the artificial setting of a randomized control trial. And this real-world evidence is nowadays very important in many of the studies. And I will give you some of the advances that took place. Let's start by the epidemiology and the clinical nephrology. In the clinical nephrology, you are aware, of course, about the empagliflozin in patients with chronic kidney disease and the nephroprotective effect of SGLT2 inhibitors. I will not speak much about it, because you see in this graph to the left, all the parameters have been improved in the EMPA arm in comparison to the placebo arm. So there is a real improvement here in the renal function by using this EMPA. But however, this is not only for the EMPA, because in this randomized control trial, in which 13 studies has been seen, you see also at the arrow that all the SGLT2 inhibitors give a good result in the kidney in this 13 randomized trial, with CKD progression of 0.6 improvement and AKI of 0.7. So there is a real nephroprotective effect increasing day by day with these SGLT2 inhibitors. The second actually advance was the finerenone. And as you know, they did another subgroup analysis of the fidelity study. They selected only the patient with chronic kidney disease stage 4 and type 2 diabetes. And astonishingly, they found that those patients with stage 4, which were here around 7% of the population studied, or 890 patients, all of them improved in finerenone versus placebo. So this was a very amazing result, giving an extra benefit of this finerenone as a nephroprotective new agent. Again, one of the important advances in clinical nephrology is trying to have a sort of mapping, mapping of the target antigen of membranous nephropathy. And you see here some of them that we know very well, which is the PLAT2R, which is present in around 65% of the patient, around 2/3 of the patient. But besides this, we have many other antigens that has been mapped and which have been disease associated. Some of them are less common, and some of them are putative antigen, and still 5 to 10% of these antigens are unknown. PLA2 now is very important, and it could prevent the biopsy. And as you see in this algorithm, if you have a PL2 level of which is high, you can diagnose membranous nephropathy without going for a renal biopsy. But if it is low, of course, you may perform a biopsy to prove the diagnosis. We have here 3 important recent studies of the treatment in membranous nephropathy, and we see the response rates in the mentor study, which is after 6 months, 12 months, and 24 months, in the cyclosporin, which is activated also by 2 doses of rituximab. And you see how much the response when you give rituximab will increase. And here it will increase from 52 to 65%, and here from 20% to 60% when you add rituximab to the 2 doses of rituximab to the treatment. And the second study is the GEM-RETUX, which study the placebo versus rituximab. And here you see after 24 months, 65% response. And the third study is the STARMAN study, in which tacrolimus plus rituximab. And again, you have after 24 months, the same figure, which is around 60% response. What is astonishing is that prednisone and cyclophosphamide give higher response at 24 months, and still they are the golden treatment of membranous nephropathy in spite of their high rate of side effects. And so old is gold, but take care of higher side effect as is seen in this table, comparing the response with corticosteroid and cyclophosphamide to the other arms, in which here we have, as you see, 77% or 92% versus tacrolimus rituximab, which are less in percentage. In the future, there will be more targets in membranous nephropathy because, as you see, some involvement of the T cell, of the B cells, and of course this receptor and the podocytes, all these could be future targets for membranous nephropathy. The second important talk that has been given in this Congress of Milan was about FSGS. As you know, FSGS is a mixture of many things. It has got genetic factors, immunological factors, toxins, infections, adaptive in obesity, for example. All these could lead to FSGS. So it is not, we are putting many fruits in one basket, but they are not the same fruits. And the presentation will be nephrotic syndrome and proteinuria, and it is different from minimal change disease, as you see here in this biopsy. You see that in minimal change disease, when you compare it by this special microscope to the healthy glomerulus, there is no much difference. But when you compare the FSGS to the healthy, you find a big hole here in this glomerulus, indicating that this is a more serious disease and it is usually steroid resistant. And it is associated actually with podocyte injury. So it is considered one of the podocytopathies. And the term is used only in the biopsy report and not as a diagnosis, and work out of podocytopathy etiology is necessary for patient management. I will jump here to give you an idea about the novel potential drugs for podocytopathies, and I will concentrate in FSGS on 3 drugs. The first will be sparsentan. In this study, as you see in the right here, the right bottom, efficacy and safety of sparsentan in patients with FSGS, which is a randomized active controlled phase 2 trial, or in the DUET study. And the second drug is the safety of dapagliflozin, as I mentioned, the SGL2 inhibitor. Also, it gives results in the FSGS. And the third drug, which is very peculiar for those who have the APOL1 gene, they found that there is a drug which inhibits this APOL1 variant, which is called inaxaplin. And as you see, the result with inaxaplin in the changing of the urinary protein ratio is very important, but unless the patient should have this APOL gene selectivity. And as you know, FSGS is more common in African American who have this APOL gene. So this drug, inaxaplin, could be a good drug for them in the future. And these are, in this cartoon, you see, in this cartoon, you may see the possible drugs that could be used in FSGS. I will start for APOL1, as I told you, inaxaplin. This if the patient has this gene. And if the immunological factor in FSGS is strong, steroid and immunosuppressants will be important. If the infections or toxins are the cause, of course, we treat the cause. And if there is a nephron overload or hyperfiltration, it is important in obese patients, for example, to decrease their body mass index. If there is genetic weakness of the podocyte, you may go to use RAS blockers, SGL2 inhibitor, or sparsentan, which, as I told you, is a combination of the endothelin inhibitor with the angiotensin receptor blocker. I think now let's go a bit about some advances in the IgA. IgA nephropathy, as you know, is one of the most important nephropathies all over the world. It is not very common in our area, but in Japan and East Asia, it is very important, also in United States and Europe. And these are the some studies about new drug, atrasentan, which is given, again, this atrasentan in phase 2 study called the affinity study to assess the efficacy and safety in patients with proteinuria glomerular disease. And you will see here the result. And there is actually reduction. 70% of the patient had baseline total urine protein more than 1 gram in the inclusion. And you will see in the response that there is proteinuric reduction in these patients after the use of the drug, which is very consistent, although the number of patients in this study was not very big. Therefore, they are trying in this, it is called a phase 2 study on 20 patients only. They are trying to go for a further study. And this further study, phase 3 study of atrasentan, will include a bigger number of patients, of course, given 0.75 milligram daily for a longer period, 132 weeks, and expected to have the results later on. Some of these patients will take, in addition, SGL2 inhibitor, or in another study, which is called the ASSIST. Some will take only SGL2 inhibitor, and other will take SGL2 in addition to atrasentan. So let's wait the result of these new drugs. Another agent used in IgA nephropathy is working by a totally different mechanism. And again, one of the main authors here is Jonathan Barat, who visited us in Egypt, and he is a famous British professor in the field of IgA nephropathy. And here he is actually addressing a new molecule, which is actually working on the APRIL. APRIL pathway triggers excess Gd-IgA1 production. And so targeting the APRIL could lead to improvement of the IgA nephropathy. This is the first hit, the second hit, the third hit, and the fourth hit, which are starting by APRIL. And so if you affect these APRIL, you may have improvement. APRIL gene variant confer increased risk of IgA nephropathy. APRIL has been shown to increase the Gd-IgA1 secretion from those patient lymphocytes, and the higher APRIL level in IgA nephropathy patient correlated with higher Gd-IgA1 and proteinuria and lower GFR. And therefore, they started to give this drug, which is called zigakibart, which is a drug which affects the APRIL. And these are the first studies of the results. And you see here a reduction of the proteinuria in this first cohort of those patients. And this is the randomization of 272 patients in what we call the Beyond study. Some of them are taking these zigakibart to see 600 milligrams subcutaneous every 2 weeks versus the placebo who are on the classic treatment. And the result is awaited. As I told you, sparsentan is not used only in focal sclerosis that I mentioned, but it is also used in IgA nephropathy. And here is a very important study about the good response of sparsentan in cases of IgA nephropathy. You see here in green the response of the proteinuria in the arm taking sparsentan versus the red who did not take the sparsentan. So there is actually some difference. Although the difference is not very big, 3% versus 6%, but it could be beneficial in the future. And there is no evidence of improvement in the eGFR, only some improvement in the protein. What about C3 glomerulopathy? Are there any new drugs coming in the management of these? Yes, there is a list of potential drugs that has been cited in Milano. iptacopan, avacopan, and this is the name of the studies, accolade here, danicopan. This drug has got only a number in the ReNew study, and pegcetacoplan. Many of these, as you from their names indicates, act on the complement pathway, the C3b and the different complement pathways, and the C3, because the complement C3 glomerulopathy, it is logic to that the drugs will be affecting the complement pathway. And here is a 10-year experience at Mayo Clinic with the outcome of these drugs. And this is a sort of algorithm by the KDIGO about the available drugs for the moment until we get the new drugs, anti-complement. You can moderate to severe disease, you give corticosteroid, MMF, eculizumab, persistent proteinuria, you may use this eculizumab, which is very expensive actually. And this is the determinant of the antiproteinuric response to these drugs in C3 glomerulopathy. Here, I will move to another aspect as I finish now the glomerular disease, and I will speak about the STOP ACE study or the RAS discontinuation. Is it, as you know from the Bandari from UK, published in the New England Journal of Medicine, they tried to compare for around 3 years those who took the ACE inhibitor and with those who didn't took. And you see here that those who continued the almost 13.3 milliliter per minute and who discontinued 12.7 milliliter per minute. So there is no much difference in the GFR between two groups, telling that let's continue in most patients to get the benefit of ACE on the cardiovascular system at least. What about the equations for the GFR? In Milan, they stressed again that the cystatin C-based equation to estimate the GFR are important. And this is a study done around 250,000 patients from Europe, US, and Africa, telling that this cystatin-based equation could be very important in the future, because there was a notion a few years ago that cystatin is not important. But now it seems that there is a revival for this. The thiazides for kidney stones recurrence, here they used actually 3 doses of thiazide, 12.5, 25, and 50, and compared that if we give the patient thiazides for preventing the stone, shall they benefit or not? And as you see in this arrow, almost no difference. So it's not very effective. Onconephrology is an important emerging field in medicine dealing with renal paraneoplastic syndromes that develop concurrently or within a few years of cancer diagnosis and improve significantly with its treatment. And it also deals with the malignancy-related kidney injury. In this respect, cancer-associated GNs like minimal lesion, membranous, etc., and include most pathological forms, anti-cancer drug toxicity, which are responsible for causing different syndromes, AKI, CKD, electrolyte, and acid-base disorders. And in this cartoon, you can see the important damages that different agents could cause to the different part of glomerulus. You see here thrombotic microangiopathy with mitomycin, for example, focal sclerosis with pamidronate and interferon, acute tubular injury with platinum, crystalline nephropathy with some agents, and tubular interstitial injury with the new tyrosine kinase inhibitors. So most of the drugs, whether the old anti-cancer or the new, are not devoid of nephrotoxicity. Kidney function is very important for the survival of cancer patients. And here you see a crucial role of having the GFR above or below 60. If the GFR is above 60, the patient survival is better. If the GFR is less than 60, the prognosis of those cancer patients will be much worse. And here, Professor Christian Combi from France tried in the last day of the Milan to summarize what happened in the dialysis. And these are the summary slide, that genetics are very important. I will mention it soon. And he is speaking much about COVID, which is not very interesting for us nowadays. And he's speaking about the anticoagulation with rivaroxaban, especially for AF patients on dialysis. He's speaking about the different dialysis techniques, including cooling the dialysate, cool dialysis and the HDF versus the high flux, the HDF versus using only high flux membranes. I will come to these in detail. Let's start by genetics in dialysis. Remember here, this AKP1 genotype, it has got 3 variants, TT, CC, and in between you have the CT. And remember, the TT is the worst. So if you have a patient with TT of this genotype, please don't put him on peritoneal dialysis, because his ultrafiltration rate will be very poor and his prognosis will be very bad. So this is a way later on to know the risk of composite death or technique failure by transferring him to hemodialysis by just doing some genetics. And I think this concept could be propagated to different aspects of nephrology. So remember, the TT is not good. What about the incremental dialysis? And here, again, they are telling, this is a big study in the UK, and they are, of course, economy oriented, and they telling the cost of incremental dialysis versus the classic 3 times dialysis, and the total cost here is 19,000 versus 26,000. And I think here, of course, definitely the incremental dialysis will use less stuff and less material, so it will be cheaper. And they are nowadays propagating it, but they are telling it is the best example of precision medicine, where we try to provide the right treatment to the right patient at the right time. So don't put an incremental dialysis patient who is not polyuric and who is not passing urine and who is have tendency for hyperkalemia. To cool or not to cool the dialysate, I mean to decrease by, for example, ½ degree. We have here 2 studies. One remember, cooling is temp. So the study is called temp. MyTemp is a Canadian study trying to cool the dialysate, and the result will be seen in this. You see here that personalized cooling of the dialysate does not cause any difference in the cardiovascular event, although it may improve to some extent the intradialytic hypotension. But this is another study coming from another place, in Italy, Spain, and Portugal, telling that cooling the bus or hemodialysis for the prevention of the hypotension could work if you decrease by ½ degree from the base. So cooling dialysis could be beneficial. Now this is the big important how we call action in this Congress, that they tried to prove a survival benefit among those who are put on high convection volume hemodiafiltration, because as you see in the old studies, the Dutch, the Italian, the French, and the Turkish, with only one exception, which is the Catalonian study, which showed a slight improvement in survival. All the other studies did not show any improvement in survival. But in the last few years, they worked on what we call the CONVINCE trial. And these are the initial publication in the NDT, trying to divide those patients into 2 groups. One group will be on 23 convection high flux, hemodiafiltration versus high flux hemodialysis. And what they found after 3 years of follow-up was very amazing, that the high dose hemodiafiltration with 23 liter gave a definite survival benefit. And this was really amazing, because this CONVINCE trial, actually all the companies which are working in dialysis were involved, Fresenius, Baxter, and all of them, B. Brown, I think also, and also the academic person. So it was not biased by any way. So the result were very not biased, and they found that actually the mortality benefit was more marked among those who are above 65 years old, And you see here this arrow showing that the high dose hemodiafiltration is better in all the aspects versus the high flux. And this actually was the شيدوفر أو أحلى حاجة اتقالت في هذا المؤتمر. But Professor Francesco Locatelli had got a comment. You should not be very enthusiastic. Currently, hemodialysis may represent a step ahead of high flux that require further long-term study. So to apply the online high-volume HDF for all patients, we are still preliminary results seem very promising, but we should not be very enthusiastic in applying this to every patient. The transplantation was actually summarized by Professor Rachel Helmans from Belgium, that started to speak about the recipient evaluation, obesity and coronary artery disease, post-transplant diabetes, DR matching, is it important or not post-transplantation, and screening for HLA antibodies. I will start by the first concept, which is the obesity and coronary artery disease. And you will be astonished that neither obesity nor coronary artery disease will prevent us from transplanting our patients. This is the conclusion of Dr. Rachel. Again, here I will give you, before going in the detail of Dr. Rachel, I will give you a snapshot of what happened in the MIZOT Congress in May in Ankara. And this was regarding the long duration kidney NMP, which can be used for 24 hours. And this study about the clinical relevance of cell-free DNA quantification and qualification during the first months after lung transplantation, because it was presented by Dr. Medhat Askar, who is a pioneer in this field, and is telling that this test, which is donor-derived DNA, offers a promising non-invasive diagnostic and monitoring tool for early detection of ABMR monitoring response, and it's very important. And he started to use it in Qatar before doing transplantation to see the rate of antibody-mediated rejection. Another important advance that has been mentioned in the MIZOT was the uterus implantation, successful uterus implantation. And it was amazing, that video, which was showing a baby coming from this uterus implant. Again, here, this xenotransplantation study by Dr. Luke Sugan, which she is a female surgeon from the University of Alabama, trying to give a criticism of the study of Professor Montgomery, that all you know, when he did a xenograft and tried to leave the native kidney, because she is telling that leaving the native kidney could not be good, because the urine could be coming from the native kidney. So if you want to get a real result, you should remove the native kidney before telling that this transplantation was successful. And she mentioned also that the porcine cytomegalovirus is actually the cause of death in the first xenotransplant from the heart, pig to human heart xenograft. And this data also was again presented in the Congress of MIZOT, telling that the cause of death in this patient was not rejection, but was the infection by the porcine cytomegalovirus, which is a latent virus. Unfortunately, take care of this sentence. This virus latency is not detected by the test. I mean, source animal would test negative by PCR. So this is a problem. You cannot know that this animal has the CMV by PCR. But after the transplantation, this porcine cytomegalovirus is activated and attacking the human and causing the death of this transplant. Professor Philip O'Connell, who is at the time the president of the TTS, gave also in Ankara an important talk about personalized medicine and artificial intelligence in the follow-up of kidney transplant patients, and the importance of the machine learning and the genomics and the predicting the biomarkers. All of these are new fields coming in the future. I will pass rapidly on these because this digital revolution, I think we are still a little bit away from it. And this is a way of how we can have a baseline interstitial and tubular abnormality score predicting 1 year graft survival. And the conclusion, this could be the future, of course, by precision medicine for transplantation. Rachel, as I told you, told us that we should transplant all patients, whether they are obese or whether they are cardiac. And her evidence was this study that the survival is still better than remaining on dialysis, whatever is the BMI. I mean, the transplant, all BMI categories, or dialysis, all BMI categories, even the obese will have a better survival. So don't hesitate to transplant an obese patient, according to her. And also, I think in the Descartes working group of ERA, they got a similar conclusion. What about should we abandon screening for occult coronary artery disease? The conclusion here after a very recent study in JAMA by Zing et al., you see here that there is no association between pre-transplant testing for coronary artery disease with death or myocardial infarction within the 30 days post-transplant. And so if the patient is asymptomatic, we recommend that asymptomatic candidates with known CAD not be revascularized exclusively to reduce the perioperative cardiac event and proceed for transplantation according to this data. So according to Rachel, transplant whether obese or coronary silent. And again, in this important Eurotransplant senior program, they used before not to get an important concentration on the HLA system, on the assumption that donor kidneys are more than 65 years, are preferentially allocated to recipient more than 65, and their immune system is weak, so the possibility of having rejection is less. But in a recent study, which is called the Eurotransplant Senior DR Compatible Program Study, they took the 2 kidneys from a dead person and give one to a person without DR matching, and the other kidney with a 0 DR mismatch. And they compared the result, and they found definitely better survival of the graft and better survival of the patient by 30% here and by 40% here when you do a proper DR matching, which goes with logic that if you do this match with DR, it is the prognosis is will be good. Screening of HLA antibody post-transplant, is it important or not? Actually, in this 13 UK transplant center on more than 2,000 patients, they found that there is no difference. Intervention did not delay the graft failure, and there is no significant benefit on GFR or proteinuria on trying to do this. And this study is called OUTS SMART study. In this, I think I finished the first part, which is Milan and Mesot, and I give you 1 minute rest before embarking into the high impact trial. Any questions?
We have a question from Dr. Manal Deep.
تفضلي يا دكتورة منال.
The cost of this high resolution microscopy.
They did not mention the cost, but it seems that we should get it. Definitely, it will be, I think, less than the electron microscopy, because it depends on the light micro. It's an improvement of the light microscopy techniques. As you know, the electron microscopy is very expensive, so it will be less than the electron microscopy. And it's very important for the research. You will find that most of the research in Kidney International, you get the biopsies colored like this with Podocin and synaptobodin and all these. I mean, most of the international researches now for biopsies are dependent on this type of microscopy.
Yes. Okay, can we proceed, please?
Yes. So now let's go to see what happened in the high impact trial in the last year. And I will start by the last slide, which is the resume. So what about the patient survival? Could we predict the patient survival by looking in what we call a glass ball? Yes, there is something called the mortality and box with 19 parameter giving 81% prediction at 10 years, and I'll give you the details later on. Could we improve the graft survival? Yes, we can improve the graft survival by having some future targets different from what we are taking nowadays. Some of them will be the TLT and the NGTI pathway that I will tell you later on. Xenotransplant, I already mentioned it, by removing the native kidney is very important not to get the urine from the native kidney. The best fluid in the first 48 hours. Are there the normal saline or something else? And the conclusion will be something else. We should use a low chloride containing fluid. The preserved transplant study, to give bicarbonate or not to give bicarbonate, and the result of it, no difference. Whether you give bicarbonate or no after transplantation, it is the same. Genetics in transplantation, I give you an idea about genetic in peritoneal dialysis. Now, genetics in transplantation, yes, especially when the patient is less than 50 years and you have a chronic kidney disease of unknown etiology. Imlifidase in transplantation and the tolerance is not near, still far, and imlifidase could be one of the targets therapeutics in the future. RNA as a medicine, yes, we'll be speaking about what we call the serans. Serans started to be used in the COVID era, and also nowadays it is used as one of the treatment of IgA nephropathy. Hypertension totally under control, not totally yet, and maybe we need some further maneuvers. And now there is some revival of the sympathectomy and trial of surgeries of denervation. IgA nephropathy advances, I give you an idea, and still some other to come. Other GN advances, especially in lupus and ANCA. What is healthy life for CKD? Exercise, water, and anemia correction. And we have new methods for anemia correction depending on tablets, not on injections, and how to delay the CKD progression. I already mentioned the IMPA kidney and the mineralocorticoid, but I will also mention the PEARL study trying to control the uric acid. Now let's embark rapidly in these, starting by the MBOX. These are the parameters of this French study from Hôpital Necker, that has been used for 10 years between 2004 and 2014 on more than 1,400 patients, taking 18 parameters to see if those patients, actually 19 parameters. Some of them are recipient factors such as age, diabetes, for example, post-transplantation parameter like the dialysis, cancer, 7 biological variables like the level of CRP, albumin, and HbA1c. And by doing some statistical method, you can speculate the mortality score from this, if the patient will live or not. These are the 19 predictors in detail, and the median post-transplant follow-up time was 7.6 years in this study. The conclusion for patient survival, we generate the first integrative patient survival score by 19 predictor that shows superior prediction performance when compared to previous prognostic system, reaching 81 prediction accuracy at 10 years. The second about the graft survival, and here we are tackling the angiopoietin tie system, which was first identified 25 years ago, regulating both cardiovascular and lymphatic development. And the angiotensin 2 is upregulated in numerous human disease. And TIE1 also promotes pro-inflammatory and pro-angiogenic signals in atherosclerosis and in tumor. High plasma level of these has been associated with cardiovascular disorders, diabetic nephropathy, CKD stage 3 to 5, and with a rapid decline in kidney function. So it could be one of the markers of prognosis in the future. And in this C-STRIDE or Chinese cohort study of chronic kidney disease, there is external validation of the NGPT2 association with the outcome. As you see here, those who have high level will have worse outcome. and therefore there are some ways targeting this new pathway by drugs. And one of these drugs will be razuprotafib, and other drugs here you see nesvacumab and faricimab, which are trying to inhibit this pathway. Number two, about the graft survival, I give you an idea about what we call the TLT, or the tertiary lymphoid tissue. Tertiary lymphoid tissue. Actually, the tertiary lymphoid tissue is a sort of combination of the T lymphocytes, B lymphocytes together. Those what we call the senescence-associated T cells and the age-associated B cells combine together with the dendritic cells and give us this tertiary lymphoid tissue. And whenever you have much tertiary lymphoid tissue, and you see here in the graft, this is an indication of an inflammation taking place, and probably kidney tissue inflammation and fibrosis that may end in graft loss. Therefore, antifibrotics could be of value in the future, and some of these antifibrotic are the well-known pirfenidone, in addition to other drugs that has been used from our colleagues in the ophthalmology, for example, in glioblastoma and pancreatic cancer, like galunisertib. For improving graft survival, future target will be the angiopoietin tie system and the tertiary lymphoid tissue by antifibrotics. Kidney xenotransplantation, I already gave you an idea about the first trial of Montgomery, and the comment given by the group of Alabama that he should have removed the kidney. This is, again, the best fluid randomized controlled trial to find whether using a balanced low chloride solution is BET plasmalite, which is a plasmalite here, as an alternative to normal saline in diseased donor kidney transplant. And it has been carried after randomization into each arm around more than 400 patients. And actually, this plasmalite was given from one of the industrial company, but the composition of it is simple. It is simply a low chloride fluid. And by adjusted relative risk here, you find adjusted risk difference of 10%, and the number needed to treat with balanced crystalloid to prevent one case of delayed graft function was only 10 patients. So it is very important. I mean, the lower the number needed to treat, the real value of using this in clinical practice. So the conclusion of the observers here, you will find, of course, that the serum creatinine is better, that the chloride level is less, the bicarbonate level is higher, all the parameters, the sodium level is lower, and so on. So the conclusion is that these findings suggest that balanced crystalloid should be the standard of care IV fluid in deceased donor kidney transplantation, because they are cheap and readily available and could be used globally. What about the preserve, the high prevalence of metabolic acidosis in kidney transplant recipient, which suggests that when you give sodium bicarb, you may get better prognosis. But what happened in this arm of alkali therapy over 2 years versus those placebo for 2 years was actually astonishing, that there was no much difference in the GFR, not different in both treatment. Only the mean blood bicarbonate level were significantly higher in the bicarbonate treated group, of course, but there is no difference in the GFR. So there is no real difference in function. Genetic first approach improved diagnostic of end-stage kidney disease, very important whenever you have a patient, a recipient less than 50 years old. And in this big study about that, you see here that the number included was 273 transplant patients, and they tried to do this genetic profile. And genetic testing in the diagnosis of chronic kidney disease recommendation for clinical practice will be the following: CKD of unknown etiology, interstitial nephropathy of unknown origin, hematuric and proteinuria nephropathy and FSGS, CKD of young age, congenital kidney abnormality, syndromic disease, cystic disease, tubular disease, and family history of chronic kidney disease. In any of these, please perform genetics before doing the transplantation. And some of the genes that could be involved, of course, apart from APOL1 that I mentioned in FSGS, many genes are important, like the SHROM3, which is one of the markers of deterioration of kidney function, and the caput, which is an important marker in pediatric nephrology, and the col B4 and 5. All of these could be important genetic testing before the age of 50 years. And this is a table of all the possibilities. The next, imlifidase. What is imlifidase? Imlifidase is simply trying to split the antibody, which is responsible for the rejection. And the hazard of the use of this drug was that maybe when you split the immunoglobulin after the transplantation, this immunoglobulin will accumulate and cause rejection again. But this long-term study for follow-up for 3 years showed that graft survival at 3 years was very good, and okay. Sorry for this stoppage because of the net. I was telling that imlifidase, which is trying to split the antibody to allow the transplantation to be done, there was a worry about it that the antibody may come back after a few weeks. But this study, which followed the patient for 3 years, was reassuring that the rate of success was around 93% in those who got an attack of antibody-mediated rejection and 77% in the other group. So it was a reassuring data that we could use this agent for long-term transplantation. What about tolerance? According to Professor Lionel Rosting, tolerance is still far because we need to reset the immune system. Maybe in the future, autologous hematopoietic stem cells transplantation could help. Some massive immune cell depletion like alemtuzumab and anti-CD52 could help. Targeting the pathogenic T cells by alifacept or belatacept, and targeting the regulatory pathway increase or enhance the T regulatory number and activity in patients. Also, in the last American Society of Nephrology Congress, there were 2 important plenary lectures, one of them about the use of RNA as a medicine. And actually, RNA does not need the big industrial biological like the different biologics, because it depends only on a simple procedure of targeting or trying to get this small RNA interference and use them in therapeutics, and we call them the CRAN, small RNA or CRANs. These can be triggered experimentally by exogenous introduction of dsRNA, which express them and inject them. And we have many drugs in this respect. Some of them has been used in COVID. Some of them has been used in the treatment of oxaluria, for primary oxaluria, and has been approved by the FDA, like lumisiran, for example. And some of them will be used in IgA nephropathy. Stop ACE, I mentioned it in the first part of my talk. And baxdrostat, which is a new aldosterone synthase selective inhibitor for resistant hypertension in this BRIG hypertension trial, published in on November 2022, shows that giving this drug for 12 weeks in half or 1 milligram or 2 milligram dose versus placebo, there is a strong control of the resistant hypertension. The olfactory receptors also in hypertension has been detected and explain in this plenary session the presence of some olfactory receptor number 78 or number 558, which are dominant in the X chromosome, I mean required for sex differences in blood pressure. So the male having two of these explain why men have higher blood pressure than women. In conclusion, regarding the IgA nephropathy also, there is an update in the treatment that I told you, give you an idea about it when we were speaking about sparsentan and we are speaking about complement pathway, but there are other additions that could be used here, like iptacopan, like eculizumab, like antibiotic regulating the gut microbiota, and like nefecon targeting the GALT system. These are some of the study of irbesartan and sparsentan. You see here the difference, 50% reduction in the baseline albuminuria versus 15% only in the irbesartan arm. And here you see the cemdisiran study, which is affecting the complement 5 pathway. And there is here in this blue arm, there is a significant decrease in the proteinuria at week 16, which was maintained until week 32 in the arm taking this cemdisiran, which is acting on complement 5 with a 37% reduction in comparison to the placebo arm. Again, iptacopan is another drug acting on the complement, and here you see also some improvement on its use, in addition to the SGLT2 inhibitor and the budesonide, which got an FDA approval. Regarding the lupus nephritis, actually we have at least 4 new drugs for lupus. We have the obinutuzumab in the NOBILITY study, which is acting like the rituximab, but a second generation of the rituximab. And we have also this Safniro or the Nephrolumab, which is a type 1 interferon receptor antagonist. We have also the voclosporin, which is a sort of calcineurin inhibitor, which has been studied and got the FDA approval, and have been studied for at least 1 year. And we have the belimumab, which is actually target the lupus, and this Benlysta or belimumab has been used for 2 years with a very good result, and it is actually present in the Middle East nowadays as subcutaneous or intravenous injection. Regarding the ANCA vasculitis, 2 recent studies recommended lower steroid doses. One of them is the LOVAS trial of 2 steroid regimen with rituximab induction, and the other study is called the PEXIVAS or the PEXI study, and both of them showed that it is better for those patients to go for lower steroid dose to avoid the long-term steroid complication. And the real advance in this field of ANCA vasculitis was the discovery that the complement has got a role in these diseases which were regarded in the past as not involving the complement. As you see here in this cartoon, the complement is present in the ANCA vasculitis. So it makes logic to attack this complement by anti-complement pathway. So in this advocate trial, which has used a phase 3 study, used the avacopan for around 1 year, you see there is improvement in the parameters, whether the proteinuria or the GFR, in those patients who got the avacopan versus those who got the placebo arm. So in pediatric also, sparsentan and ofatumumab could be used in pediatric nephrology. In membranous, don't use immunosuppressive if the titer of low anti-PAR is very low. And for chronic kidney disease progression, please don't smoke. Try to reduce your weight, physical activity, and healthy diet, according to the recommendation of Charlene from the United Kingdom, who came to us in our Egyptian Congress. Drink much water, but not too much, not more than half a liter. And not as low as half a liter or not more than 2 liters, because according to this CKD RAIN study, there is a U shape. If you drink too much, the hazard of renal failure is high, and if you drink too little, the hazard of renal failure also will be high. Anemia could be controlled. Those 3 persons got the Nobel Prize in Physiology in 2019 by discovering how cells sense and adapted to oxygen availability, especially in high altitude. And these new drugs, which are the HEF stabilizer, propyl hydroxylase inhibitors, try to increase endogenous erythropoietin, which may come not only from the kidney, but from other sites, and also may improve the iron status of those patients. And now that we have many drugs got an FDA approval, like daprodustat, or an European approval like roxadustat. Roxadustat is given 3 times per week, and while daprodustat is given daily. And these, I think, in the future will be a real addition to the armamentarium of treatment of anemia. Could we delay CKD progression? It is increasing. CKD is increasing. It will be in 2040 the 5th cause of death in the world, and in 1990 it was only 11 million, 1216 increasing, and 2040 increasing more and more. Because there is many cases of hypertension, many cases of diabetes, and many cases of undetected etiology for renal disease. Could we prevent this loss? Possibly by controlling uric acid, but this has not been proven in the PEARL study, although many authors from the United States were thinking that uric acid could be a cause, but it has not been proved in this 3 years follow-up study. SGL2 inhibitor could, as I told you, you see here there is a difference between the violet arm of IMPA versus placebo in the kidney disease progression. And also you can give not only this, but you can use also finerenone, which gives 18% improvement versus placebo. And combining all these drugs together, you may delay the progression of renal disease. I think in this way, I finished the updates from recent nephrology congresses, and sorry to be too long today. Thank you.
Thank you, Professor Hani. It was really very interesting, and in spite of many slides, we did not get bored at all. It is a very, very, very interesting session, and anyone can observe that nephrology now becomes a promising branch, and young physician have many to do today, not like the past days. Many drugs, many trials, many diagnostic methods regarding pathology, biochemical markers, and etc. And many drugs targeting glomerulonephritis, targeting transplantation, and genetic work in nephrology now is one of the promising branches regarding genetic therapy and targeting these genetic targets. Thank you so much, and we can open the discussion. I can see many professors waiting for their comment. Let we start by Professor Dawla Bilal. Professor Dawla Bilal, please. Unmute yourself. So, Professor Hisham Said.
Thank you very much, Professor Dr. Hani. It's again around the world in 1.5 hours. So we have a lot of job to do. It's amazing that to cover all of these issues in 1.5 hours, making a decade for reading such conclusions and such papers in different aspects. As usual, we enjoyed that, and actually, I am astonishing that. Yes, I'm astonished that when all these clinical trials will be on hand, so a nephrologist can have a positive impact for CKD progression. Just I have a comment, not a question in the analysis for sure. According to pentraxine, you highlight that in the first few slides. Pentraxine is a nightmare in dialysis. Pentraxine is the cause of endothelial dysfunction, and nitric oxide synthase inhibitor. It's a very huge molecule to be removed by dialysis simply. So I wish that in a time we have a targeting drugs that can attack big molecules that cause endothelial dysfunction, subsequently cardiovascular death. Other issues are expressed very exciting, although not too much at our hand today, but it's very optimistic for the upcoming decade, inshallah.
Inshallah. Thank you very much for your comment, دكتور هشام. طبعا هو دلوقتي يعني ال development of targeting molecules is becoming much easier يعني in the laboratory.
Exactly.
يعني هم بيحاولوا ان هم يشوفوا الموليكيول ويبتدوا على طول يعملوا انتي بودي او سيرانز ضدها. بتبقى البروسيس سهل عن زمان. زمان كان بتبقى بتعمل ترايل على بال ما تلاقي التارجت المظبوط على قد الموليكيول ده، كنت بتاخد وقت طويل. دلوقتي it's much easier يعني.
Yes, it may improve the survival in dialysis, attacking directly the molecule of cardiovascular death and endothelial dysfunction.
Okay, thank you, Professor Hisham. Professor Hani, I have a question about cystatin C. Do you have an explanation why this marker did not get any priority in estimation of GFR over these long years? And if you remember, we have
a new study دكتور ياسر بتقول ان هو has got good benefit على حوالي 250,000 عيان.
This is the second part of my question. This is not the first new study for cystatin. Many studies we're going over these past years, and
كانت نيجاتيف. most of studies قبل كده كانت نيجاتيف. كانت نيجاتيف لكن هو دي
priority.
الاستادي دي جايبه بوزيتيف ريزلت. فيعني غالبا هو احنا في البراكتس الحقيقه it seems ان الموليكيول دي فعلا بتبقى مور اكيوريت شويه عن الكرياتينين، لان احنا لونج اجو يعني بقالنا كتير جدا ما عندناش حاجه اكتر من الكرياتينين. we need to have something practical and not very expensive to be used in our daily life. Yeah.
I can remember in the early of this century, in the mid 2000s, that we were told that we are to start using cystatin in our routine clinical practice, and some labs started to receive the kits and prepare themselves for using it as a routine method for estimation of GFR. Unfortunately, all of this stopped and back to creatinine, and every time we are back to creatinine. And if you remember, we have one of our studies in critical ill patient, me and you, regarding this molecule and its equations, and at the same results we get regarding critical ill patient, no more superiority of this cystatin C over creatinine. But nowadays you gave us a different hope for this molecule, hope to have another molecule other than cystatin. We have a question.
I will get the chance ان الدكتوره دينا معانا كمان. دكتوره دينا عبد اللطيف موجوده عشان there was a recent study of some detection of the kidney function by using the saliva. I mean, by getting a saliva sample, not a blood sample. فأعتقد إن دينا oriented بالموضوع ده وبتعمل عليه some research. في أسئلة تانية؟
Okay, if you have a
معلش
question.
I was mute. ما كنتش عارفة أشيل الميوت. I was mute. عمالة أجاوب. هو لسه يعني لسه بنبتدي، وhopefully إن ده يبقى يعني easy diagnostic tool اللي هتبقى applicable very soon. فيعني hopefully كده مثلا by the end of the year ولا حاجة ممكن يبقى في عندنا شوية results of the screening.
Okay, we have a question from Dr. Rami Abu Bakr, our coordinator today, about the stop ACE trial and your practice, Professor Hani, in stopping ACE inhibitor or continuing ACE inhibitors in stage 5 CKD.
هو طبعا الستوب ACE study كان عليها some concern in the number of patients in the study was not very big. يعني كل each arm كان حوالي 400 patients. وفي نفس الوقت كان the results were almost equivocal بالنسبه للجي اف ار، واحد 13 والثاني 12، يعني كانوا قريبين قوي من بعض. وبالتالي I think you have the choice. You have the choice to either to stop or to continue. My personal يعني preference is to stop الحقيقه، لانه I am afraid شويه من الهايبركاليميا اللي بتحصل، و I am afraid برضو من يعني at a certain time those patients are not very meticulous in the follow-up visits. يعني ممكن البيشنت مثلا يكون قاعد in a governorate away from Cairo coming after 3 months مثلا، فممكن قوي ال continuing use of the aids while he has a creatinine مثلا of 5 ممكن يعمل له hyperkalemia او يعمل له problems not detected. فيعني I am in those who stop. This is my personal يعني.
Professor Hisham Said completes the answer that unless for cardiac reason, of course other
طبعا yes if there is a strong يعني indication in the patient يعني عنده heart disease significant, yes يبقى ساعتها it outweighs the risk, yes يساوي يعني.
Question from Professor Manal Deep: Can we use finerenone in stage 4 CKD as you mentioned?
Yes, this is the study that I showed على around more than 800 patient. هم عملوا sub study من الفيديليو على البيشنتس دول اللي هم ستيج 4، ولقوا ان هو هيبقى very effective وجاب نتيجه كويسه في ال 800 patient اللي هي sub study من الفيديليو الاصليه يعني. اتقالت في ميلانو يعني.
Okay. Last question from Dr. Walid Al-Kirani asking, I think this should we continue on SGLT2 inhibitors in CKD4 proteinuria to slow progression, or we should stop?
On SGLT2 inhibitors
in stage 4, I think Impa Kidney answered this question and DAPA CKD.
يعني ما هو الفكره ان هم they went down up to around 20 GFR. فده مش هيبقى ستيج 4 قوي يعني. ستيج 4 هيبقى اقل من كده كمان.
ليه ستيج 4؟
يعني لغايه ستيج 3 مثلا، ممكن لغايه ستيج 3. لكن I think 4 هيبقى اجريسيف شويه، اننا يعني هتبقى انت على الحدود بتاعت 4.
يعني في اللاست بارت اوف ستيج 4.
بالظبط.
بروفيسور هشام السيد.
Yes, sorry, I was trying to unmute myself. It allowed me, Professor Dr. Hani, just to add a few comments on SGLT inhibitor. If the patient is already on sodium glucose co-transporters and the GFR is declining up to the stage 4, even the DAPA-CKD showed that significant post-hoc analysis, significant reduction of progression and proteinuria. So to continue, yes. To start, no.
To start, no. بالظبط كده، صح يا دكتور هشام. يعني هو if he is already on it, he can continue. Yes.
Because simply
but you don't start a patient on it while he's very
exactly, because when starting there is a sharp drop of GFR. So if you started below 20, it may be dropped to 10, and so it will be risky.
Risky.
And I think it is mentioned in guidelines, continue up to dialysis. You can continue up to dialysis.
And even now is looking for a trial on dialysis patients to maintain the residual kidney function.
This is the new question today. Okay. We have no more comments and no more questions, Professor Hani, and we can close. Excuse me to close.
Thank you very much. It's my pleasure to be with you, and I hope I was not very heavy today on you.
Thank you, Professor Hani, for this very, very, very interesting session. And a long journey and very interesting journey through the last nephrology congresses all over the world, and we are waiting for you, if I still present in this platform next year, to take another journey for the coming congresses over the coming year. Thank you so much. I enjoyed this very, very much, and thank you for this highly
كل
scientific
سنة
session.
وانتم طيبين وعيد أضحى مبارك. كل سنة وانتم
كل
طيبين.
سنة وحضراتكم طيبين. We will stop next week for the Eid al-Adha, and coming the week after, the lecture will be by, excuse me, to be by me this time, about the biochemical markers of acute kidney injury, and another lecture by my coordinator today, our coordinator today, Professor Dr. Rami Abu Bakr, about the antiphospholipase A2 receptors in glomerulonephritis. Thank you very much, and excuse me to close. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
شكرا جزيلا. شكرا.
شكرا جزيلا.